Good day, everyone. I am Dr. Prakash Singh Wasan presenting a paper under unilateral twin tubal ectopic pregnancy with cardiac activity in spontaneous conception, a rare sonographic diagnosis. So, ectopic pregnancy occurs when a blastocyst abnormally implants outside the endometrium of the uterus. The incidence of ectopic pregnancy has increased since the introduction of the assisted reproductive technique and tuboplasty. If mismanaged, this is potentially life-threatening condition. So in this index case is a presenting case of a unilateral twin ectopic pregnancy in a spontaneous conception with cardiac activity demonstrated in both the embryonic poles. Ectopic pregnancy results from implantation outside the uterine cavity. Incidence has increased with ART. Twin pregnancy remains exceedingly rare, less than 1%. The presence of cardiac activity significantly increases the risk of rupture and maternal morbidity. Early diagnosis on transvaginal ultrasound is life-saving. This paper presents an index case of unilateral live tubal ectopic pregnancy, supplemented by a focused review of similar reported cases from literature to highlight diagnostic sonographic features. So why this case is unique? Twin tubal ectopic pregnancy is extremely rare. The presence of cardiac activity in both the embryos significantly increases the rupture risk. It has occurred in a spontaneous conception, not ART, our index case, and patient was asymptomatic and diagnosis was purely made on transvaginal ultrasound. So the learning objective is to recognize after reviewing this case, we will be able to recognize the sonographic criteria for diagnosing twin tubal ectopic pregnancy on transvaginal ultrasound, systematically evaluate the adnexa and UPT positive patient with an empty uterus, differentiate twin ectopic pregnancy from common adnexal mimics such as corpus luteal cyst and hemorrhagic ovarian cyst. Fourth point being understand the prognostic and management implication of fetal cardiac activity in ectopic pregnancy. Last learning objective being avoid common diagnostic pitfalls that may delay diagnosis and increase maternal risk. This is a G2P1L1 female with a 10-week one-day amenorrhea with UPT positive following spontaneous conception. She had previous LSCS and was asymptomatic, presenting only for dating scan. There was no abdominal pain or vaginal bleeding, and she was hemodynamically stable. So on our ultrasound images, we see two fetal poles noted in the right adnexa with cardiac activity and corresponding to gestational age of 7 weeks. Also, mild free fluid was noted in the pouch of ductless. So, in our case, the TVS finding shows an empty uterus. Transvaginal ultrasound demonstrated a decidual reaction with an endometrium with no evidence of intrauterine gestational sac or a pseudosac. On next image, a gestational sac was identified. The gestational sac was identified in the right adnexa and ovary was seen separately, confirming its adnexal origin. Here we can see the ovary and the gestational sac separately. So on this image, we can see two embryonic poles were visualized within the adnexa. One CRL measuring 13 mm and other fetus B measuring 9.7 mm, demonstrating the CRL discordance, as we can see here. The cardiac activity was also demonstrated in both the embryos, indicating high risk of rupture, necessitating urgent management. So this is, now we are going to see the literature cases. The literature cases demonstrates a twin ectopic pregnancy. The image A shows a sagittal and a sagittal view of the right fallopian tube containing two discrete gestational sac. And in an image B, we can see a transverse view again confirming two separate sacs within the tube. So this is another literature case where it demonstrates a twin ectopic pregnancy in the interstitial portion of the right tube. The gestational sac is seen clearly surrounded by a asymmetric myometrial mantle, a key imaging feature suggestive of interstitial ectopic pregnancy. This is another literature case, which is a symptomatic twin ectopic pregnancy. This case involves a 35-year-old female presenting with a lower abdominal pain for 3 days. and 8 weeks of amenorrhea and per vaginal bleeding. She had one previous full-term delivery and two spontaneous abortion previously. And here we can see the uterus is normal in size, and we see a heterogeneous mass in the right adnexa measuring 7.5 into 5.1 centimeter, a sac-like structure with two fetal pole, as we can see here, one CRL fetus A measuring 14 corresponding to 7 weeks 5 days, and CRL B corresponding to 7 weeks 5 days. Similar, and mild free fluid was seen in the abdomen, pseudosac within the endometrial cavity, and both ovaries were visualized separately. So the fetal cardiac activity was present in both the both the embryos as seen in this image. The presence of cardiac activity confers a high risk of rupture. The patient was urgently referred for surgical management. Early diagnosis is prevented for catastrophic hemorrhage, and the maternal outcome was favorable. The key sonographic pearls were the empty uterus with decidual reaction does not always equals to intrauterine pregnancy. Always identify ovaries separately from adnexal mass. The cardiac activity in ectopic that equates to surgical urgency. The CRL discordance can occur in twin ectopic, like seen in our index case. Free fluid may be minimal even with viable ectopic. Conclusion: when making a diagnosis of ectopic pregnancy, even though rare, the chances of twin implantation has to be considered. With the advent and assisted reproductive technologies, the incidence of ectopic pregnancy has increased. Hence, with early detection of ectopic, patient can be treated with less invasive medical therapy. A meticulous transvaginal ultrasound with systematic adnexal evaluation is essential in all UPT positive patients, even in absence of symptoms. Thank you.